Oh, is that your son? बेटे को तो सामने दिखाओ, Ali.
It's not my son. I am helping out Yusuf Khan.
Okay, Assalamualaikum.
Yusuf
So that's
Khan,
Assalamualaikum.
Dr. Khan.
I'm with the DMV. So.
Oh, okay.
Yeah.
I just saw a slide and I was like, maybe it's your son.
No, Bobby. Bobby, can you go on your phone and go to the page? We are live on Facebook. Check it out.
My phone is dead.
Oh, okay. Right.
It's in my trunk. I'm sure if you're saying it's live, it's live.
We are live on Facebook right now. If any of the other executive committee members would like to share it, they're more than welcome to share it. You're good right now. Let's see. I've got, how many people do I have? I've got 5 people. And Dr. Rator, sir, assalamu alaikum. You are not muted, but I think you might be away from your computer. I'm willing to bet that you are away from your computer because you are not muted. And then Nazia Papi is the only other one that is not muted. And we've got Ms. Qayyum, Ms. Khan, and another Ms. Khan that just joined. So there's 6 of us right now. And I've got the questions, Nazia Papi, that you gave me. We can definitely get those.
Okay, let's wait till, let's see what the members are asking. And, I received some questions through emails.
Yeah.
So
we have Mr.
Is Dr.
Alaikum.
Assalamualaikum.
Can you guys hear me?
Yes, sir. Assalamu alaikum.
Assalamualaikum, Mubin bhai.
Dr. Rator, assalamu alaikum, sir. How are you? I think you might be on mute now. Yeah, he's on mute.
And you can't unmute him?
I can only ask to unmute somebody because of privacy. They have to be the one to accept that unmute. So. But I think he means to be on mute because he's on the phone at the moment.
Oh, okay. That's fine.
I really wish you had your phone because maybe people want to reach out to you. So charge kar lena. Can you charge your phone? Is it
my truck? I'll have to go down in the garage.
Can you guys hear me?
Because my only thing is that I don't know if you.
Yeah. Assalamualaikum. I can hear him.
Okay.
Ali, can you hear him? I can.
I cannot hear Dr. Rator.
Because I just heard.
Problem. And I unplugged this and then I plugged it back in.
I can hear him now. Sir?
Okay.
Dr. Rator.
When is your last interview?
Assalamualaikum.
This was plugged in and it wasn't working. I plugged it back in.
Can you hear me?
Yes, sir.
Assalamualaikum.
Dr. Islam, I am not able to share my screen.
I can give you that right, sir. That's not a problem.
I sent a message in the chat box to do that.
Oh, you did? Hold on, chat. I didn't get anything in the message, sir.
No, it's in the chat box. It says,
not to worry. I'm gonna make you. I can make you a host. Okay, you are now the host, sir. My name is Ali, and I'm supporting Nazia Pabi with this, and I'm supporting Alliance.
all right, can you see the slides?
Yes, sir.
Yeah.
Okay, very good.
Perfect. And sir, I just want to let you know that we are. Actually, let me start recording this, but I can't because you are the host. This is going to be tricky because you're the host now. I wonder, can you share Dr. Rator, do you want to email me your presentation?
It's a little complicated because I've got 400 slides and this is a custom slideshow.
Oh, because I need to also manage who's coming in and the mutes and this and that. And
I can be the co-host.
yeah, let me see. I don't think it allows us.
It
me
does.
to have-
It does.
It does? Okay, hold on. Why? Can you grant me, or do you know how to make me a co-host?
I think so. Hold on a second.
All
Well,
right.
I don't know if I know how to make you a co-host, but I've done this before. If I can get to it now. I think I have to get out of my, let's see here.
'Cause I want to, for example, I want to record and it's not letting me record because I'm not the host at the moment. So.
Ali, you are not showing up here. Oh, Alliance EC, is that you?
Yes, yes.
Let me see what happens when I do that. I know there's a way to have co-host, but let's see. Do you want to change the host? No, that won't work. Let's see here. I know there's a way to do co-host. I don't know. My secretary knows that. She does it all the time.
So I just sent you a message saying request remote control. I wonder if, oh no, that just gives me remote.
But that gives you control of the screen. Let's see what.
Yeah.
That means you will have to forward the slides every time. That wastes time.
Yep.
Why don't you do a quick Google search and see how to make Zoom co-host?
Yeah, let me see.
मुबीन भाई अस्सलाम वालेकुम।
वालेकुम सलाम श्रेया, कैसे हैं आप?
मैं ठीक हूँ बिल्कुल, आप कैसे हैं?
ठीक ठाक। ताज का क्या हाल है?
सबके ठीक ठाक हैं बिल्कुल। ताज अभी ट्रैवल कर रहे हैं तो इंशाल्लाह वो रिकॉर्डिंग देखेंगे आपकी।
वो कहाँ जाके इस कोविड के मौसम में कहाँ ट्रैवल कर रहा है वो?
अल्पासो गए हुए हैं, आज आ रहे हैं वापस।
पेशेंट्स देख रहा है।
हाँ,
तो बाय रोड जाता है बाय एयर?
बाय एयर।
अच्छा।
हाँ, तो वो बस।
और बच्चों का क्या हाल है?
बच्चे बिल्कुल ठीक ठाक हैं अल्हम्दुलिल्लाह। ख़याम इज इन एलए, रमी इज इन ही इज इन ह्यूस्टन राइट नाउ।
Last I talked to him, he was in Tampa, I think.
Yes, that's right. He was heading the Engage what's it called? Chapter.
Taj bhai, assalamu alaikum. You are muted, Taj. Taj just joined.
But Taj joined almost an hour ago, and
So Dr. Rator, if you go on top of it saying click on manage participants in the meeting controls, and then
The only thing I have is participants. I can click on that. And then what do I do?
hover over the name of the participant who's going to be a co-host,
Yeah.
and then choose more,
Yeah.
and then click make co-host.
I don't have that ability.
You do not.
Why you have that ability?
Can you make me up?
Yeah.
I don't have, at the moment, I don't have any ability.
Okay, I'll make you host and then you can make me co-host. There you go.
Let me see. Let me check it out. Okay, here we go. Let me.
Ria, can you do all this? All this technical stuff?
me? No, I have
Yeah.
no idea what they're talking about. I just
That's
don't,
exactly.
launch a Zoom meeting, and that's it.
Ali,
Yes, sir.
I can move the slides, so you don't have to make me co-host.
Okay.
Yeah.
All right, great. Okay, wonderful. Let me, I need to start recording this. Okay, perfect. We are also live on Facebook.
Okay.
Dr. Rator, just wanted to give you a heads up.
All right. No worries.
Yes.
Sorry, we had to take care of those technical things. We have about 10 people on the.
There are 13 folks right now. Yes.
I'm ready whenever you guys are.
Ali, is it time?
It's 12:02. I think it's safe to say we can get started.
Okay. Assalamu alaikum and good afternoon, everyone. I'm Nazia Imtiaz Hussain, Alliance President. Thank you for joining in today's very important and pertinent webinar. Today, we will be talking with Dr. Mubin Rathore, who is an infectious disease specialist in Jacksonville, Florida, in regarding the myths surrounding the COVID-19 vaccine. Vaccines, as we know, it is widely considered to be one of the greatest inventions of mankind. The World Health Organization estimates that vaccines prevented over 10 million deaths between 2010 and 2015, and many millions more were protected from different illnesses. Despite this, there is a lot of misinformation and misconceptions about vaccines that contribute to this growing problem. As we all know, the United States approved the first vaccine for COVID-19 prevention. Yet, as scientists explain how the new vaccines are made and experts are expressing their confidence in their safety, many myths about these are circulating. Yet, as of now, many Americans are reluctant when it comes to trusting the vaccine due to the number of fast-spreading conspiracy theories. So we are airing out the truth and debunking the most dangerous myths about the coronavirus vaccine. COVID-19 has been around for most of 2020, and we're learning more about the disease every day. And yet, there's still a lot of misinformation circulating on the internet and social media. It can be easy to jump down a rabbit hole of fake news when surfing the web or scrolling through your Facebook or Twitter feed. This misinformation can lead to paranoia and can even cause someone to try something dangerous to cure or prevent COVID-19. So to give us the facts about the vaccine, I'm pleased to now introduce Dr. Rathore. Dr. Mubin Rathore is Chief of Infectious Diseases for University of Florida Health Jacksonville and Wolfson Children's Hospital, and Professor and Associate Chair for the University of Florida College of Medicine, Jacksonville. He is the founding director of UF Center for HIV AIDS Research, Education and Service. Dr. Rathore has served on the board of Wolfson Children's Hospital and University of Florida Jacksonville Practice Plan. Dr. Rathore is an infectious disease specialist in Florida and has been practicing for 29 years. He graduated from King Edward Medical College in 1983 and specializes in infectious disease medicine. Dr. Mubin Rathore specializes in pediatrics, infectious diseases, cares for children through the diagnosis, treatment, and prevention of infectious diseases. Dr. Rathore has not only closed the town and gown gap in medicine, but he is also very active in the community, serving on the boards of One Jacks, a diversity inclusion advocacy organization, and the Environmental Protection Board. He is the president of the Board of Mass Free Clinic for the Uninsured and president-elect of Leadership Jacksonville. A fervent advocate for all children and especially children with HIV, he has been instrumental in the improvement of HIV care of children and pregnant women in the state of Florida. Dr. Mubin Rathore, thank you very much for making time out of your busy schedule to join us today. Please welcome our esteemed guest, Dr. Mubin.
Thank you, Nazia. It's indeed a pleasure to be here. I'm going to start with some slides and then we'll leave hopefully a lot of time for questions. I just wanted to dedicate this talk to my father who passed away recently in Pakistan at a young age of 90. Many of you probably don't recognize this good-looking man. He's the last case of smallpox in the world, and so it becomes a very important figure in medicine. This young lady is the first person to receive COVID vaccine in the Western world, and I just wanted to mention these things because these are historic moments. There are many vaccines that are in the pipeline that last counted were like 150 different vaccines. Some of them are much more advanced than others. The two that are approved, I've listed some of the ones that are more advanced in their research and closer to perhaps getting approved or in the next months of years. But two of them, BioNTech, Pfizer, and Moderna, are approved in the United States. The University of Oxford AstraZeneca is approved in the UK, and the J&J vaccine, the Novavax, and the Sanofi vaccines are currently in trial, and will probably be these four vaccines that are in bold black are going to be the ones that are going to be approved next in the United States. So the other vaccines are at various levels of research, and we expect to have several vaccines available. So when we are talking about the vaccine, what we are really looking at is this a vaccine that can produce antibodies against a spike protein. I'm sure all of you have heard that in the news. And that's the key protein that if antibodies are produced against that, one can be protected against the infection with COVID-19. I want to show you this cartoon because I like this. There are many different types of vaccines that can be made. The two that we are not going to make for COVID-19 are the whole inactivated and the live attenuated, for obvious reasons, because of the risk of infection from the vaccine. The vaccines that are already available, the BioNTech and Moderna vaccines, are the messenger RNA vaccines. And the ones that are the AstraZeneca, University of Oxford, and the Janssen vaccine, or the J&J vaccine, are recombinant viral vector vaccines. This is the messenger RNA is these COVID vaccines from the messenger RNAs are the first vaccine in this class. The recombinant viral vector vaccines, we have several of them already being used, like the hepatitis B vaccine. And of course, the Novavax and Sanofi vaccine are the more traditional types of vaccine, which is protein. And there's some other vaccines that are also going to be are different categories that are being studied also. So I like this cartoon because it allows me to understand better some of the concerns and issues around the vaccine. The question really, the first and most important question people ask is, can vaccines cause SARS-CoV-2 infection or cause COVID-19 illness? And the answer to that is an emphatic no, it cannot. The vaccines that are being tested right now are all from synthetic products. As I told you, we are not using inactivated viral products or the attenuated viral products. These are all synthetic. They're all made in the lab. These are artificial pieces that are copied from the SARS-CoV-2 virus, but they're not natural. And so they are not the whole virus. They're just a part of the virus. Therefore, these vaccines cannot cause infection. And the analogy that I like is, if you have a bicycle wheel, a bicycle handle, and a bicycle chain, that will not make a bicycle. So same be if you have the messenger RNA, you have the nanoparticle vector, and you have the spike protein, that does not form the virus. So just keep that in mind, that that's how we believe that the vaccine is safe and will not cause infection once they are taken. The way the vaccines are made in general, this is a good cartoon. I like this. It helps me understand better. The various vaccines that are in research or approved can all be covered under this cartoon. So first there's the genetic code. If you talk about the messenger RNA, and that's what the messenger RNA does. And then the messenger RNA needs a vector to, which is a vehicle that is necessary to get the vaccine into the human body. And that's the vector that for a sandwich, you can look at that as the bread. And then the antigen, which is really the meat of it, no pun intended, is what really makes the body respond and produce antibodies. And some of these vaccines then have adjuvants, which basically spike the vaccine, just as in condiment spikes the sandwich and makes it more delicious. The adjuvant makes the vaccine more powerful, and the body's response to that vaccine is much more robust. So that's how I believe we could think of the vaccines, various type of vaccines that we have. I like this because this shows that the young man in yellow shirt and no shoes, that's the guy who is a Turkish immigrant to Germany. He's the one who's formed the BioNTech company, and he and his wife are responsible for making this vaccine, the Pfizer BioNTech vaccine, the first vaccine approved in the United States. And I think I want you to all look at this and remember this, that the Ogersign and his wife, Azalem Torsay, who are both Muslims from Turkey, and they are the ones who are responsible for creating the first vaccine in the Western world so that we can be protected against COVID-19. So what are Moderna and BioNTech Pfizer vaccines? They are both messenger RNA vaccines. They have Moderna test experiment vaccine is called mRNA 1273, and the BioNTech is 162b2. I mean, these are just numbers. What happens is when you're producing these proteins in the lab, you have many proteins and you give them numbers, and then you test each of those proteins to see which is going to be most effective. And in this particular in case of Moderna, it was mRNA 1273, and in case of BioNTech, it was BNT 162b2. BNT 162b1 was also promising, but not as promising as B2, and so that was not moved further. These are all enclosed in a lipid nanoparticle, both of these the messenger RNAs, and that's one of the things that causes that local reaction and the side effects that we expect to have with these vaccines, the local reactogenicity and the systemic reactogenicity. The Moderna vaccine is 0 to 28 days, and the Pfizer vaccine is 0 to 21 days. There are 2 doses of each of these vaccines. I'm going to talk a little bit. So I think what I want to stress here is even if we get the vaccine, we have to continue our other prevention processes, because these vaccines were studied to see the prevention of disease, not infection. What that means is only those participants in the study, they were tested for coronavirus only if they got symptomatic. It would be mild symptoms, but anybody who had symptoms was tested. And if you can still get the infection and be asymptomatic. So in infectious diseases, there's a concept of colonization, infection, and disease. Everybody who gets colonized does not get infected. Everybody who gets infected does not get the disease. So in these 2 studies, they tested for disease, not the infection. Now it's possible that these vaccines prevent the infection. We just don't know. So whenever you have a vaccine, there are some critical factors and there are some important factors that we have to look at. Vaccine is the only drug in our armamentarium that we actually give to healthy people. So the bar for safety for the vaccines is much higher. That is why vaccine trials have thousands and tens of thousands of participants as opposed to other drug trials. But what's critical for the vaccine is the safety, safety, adverse effects, and efficacy. While efficacy is critical, it is extremely important that the vaccine be safe and does not have too many adverse effects, so it can be tolerated. Tolerability is important, but depending on how serious the disease is, we should be willing to have some local reactogenicity that would make the vaccine less tolerable, but tolerable as long as it is for a short period of time. I can tell you, I got my 2nd dose yesterday, and both doses, I get a little bit of a fever, headache, aches and pains, and I have that. I've gotten the vaccine like 10 o'clock both times, and by 4 o'clock I have that, and I go to sleep, and next morning, like today, I'm just fine. So we need a vaccine that is tolerable, but most importantly, must be safe and efficacious. And this vaccine, although it has some adverse events, is still tolerable. I think I have some, yeah, here you go. Those of us who have had the shingles vaccine, Shingrix, we need to understand that all vaccines have reactogenicity. It seems that some vaccines more than the others. Even placebo has reactogenicity, as you can see in this slide, 13% of the cases. But I had Shingrix several months ago, and I had the same sort of reactogenicity, pain, not feeling well, achy, just feeling crappy. And the Pfizer BioNTech vaccine, Moderna vaccine would have same sort of reactogenicity, although not as bad as Shingrix, but much worse than what you would see with some of the flu vaccines. This is a slide I created very early on when the vaccine became available. And in December 2020, we were going to immunize the frontline health workers. Unfortunately, in our hospital, 47% of the frontline healthcare workers declined the vaccine, which is really a shame. At other healthcare organizations, it's been as much as 60%. And then, of course, in January, people were supposed to get the 2nd dose. It was expected by February, March, people more than 65 years, especially more than 75 years, and those with underlying medical conditions and other essential workers will get the vaccine. Depending on the state, like for the state of Florida, the governor decided to give the vaccine to those more than 65 years of age back in December. Other states have done it differently. I think we all know, I was hoping that by April, June, most people in the United States would have access to the vaccine. But as I said back there, I think Murphy would be around and we should expect delays. And that's exactly what has happened. I'm hoping now that we will ramp up the vaccination and really need to open it up for everyone. So whoever is interested can at least get it. My hope was that by December 2021, most people will be vaccinated and we can get back to normal what we had before the pandemic. So let me now talk about some of the myths and hopefully we can debunk them. First thing is COVID vaccine ingredients are haram. You know, I'm going to talk about this. Let me just go through this first and I will make a comment. COVID vaccine does not have any animal ingredients at all. So I don't know what this haram business is. They have been declared halal by the majority of scholarly bodies worldwide. Unfortunately, there are still some Maulvis who all their job is to give idiotic fatwas, and this is one of them, what they have done. Some vaccines in the past use special fetal cell lines to grow the virus, and this was the only option at that time. Messenger RNA, one of the reasons we can produce this vaccine very fast is because it is produced, protein is produced in the lab. And these cell lines are no more used. My comment was that even if we were using something that was porcine, if you can save a life, I think, you know, I'm not a Muslim scholar, but I would think the sanctity of life is so much that when we are allowed to even eat haram, if our life is in danger, there's no reason we can't use that. But although there's no such thing here in this product, people have been using porcine insulin for years. People have had porcine valves for heart valves for years. So I think this is a little bit of just, you know, idiocy to say that this is haram. COVID vaccine will have a microchip and will track the population. This is one of those other conspiracy theories. I think it is, although it is laughable to most of them, but believe it or not, some people do believe this to be the true. You know, your phones, your credit cards, people can track you by the use much better. So, you know, if you think that we are not being tracked by those, and this is going to do that, we are a part of the COVID vaccine prevention network, and I'm very knowledgeable about these vaccine trials, and we'll be participating in some of them also. I mean, there's no such thing. I don't even know how people come up with these things. COVID vaccine is just another money-making opportunity for big pharma. This is usually not true for vaccines. Vaccines do not make big pharma a lot of money. There is a lot of investment in there. But specifically for the COVID vaccine, most pharmaceutical companies are providing the vaccine at minimal or no profit. And they have also received large amount of federal funding through Operation Warp Speed, so that the government bought the vaccine at cost, basically. In fact, University of Oxford, AstraZeneca is waiving the patents, I should say patent, not patients, in giving technology free to some pharmaceutical companies in resource-limited countries such as India, that they are in Brazil and I believe South Africa. They'll be producing those vaccines locally. COVID vaccine will modify my DNA. Messenger RNA cannot change DNA of the cell. It is a messenger RNA. It doesn't even get into the nucleus of the cell where the DNA resides. The messenger RNA teaches the cell ribosome to make the protein for the body's immune system to respond with antibody production, and then it dissipates after doing its job. So it's not even there anymore. It is better to wait for herd immunity by natural diseases, and so we don't need the vaccine. This is another one of those myths. There's no evidence in the history of infectious diseases that any infectious disease has ever been eliminated by achieving natural herd immunity. Even if you try to do that, there's going to be need for the infection to be in more than 75% of the population, and this will result in millions and millions of deaths that would not occur if we get the herd immunity by the vaccine. The benefits of the vaccine far outweigh the risk of natural infection. The side effects that I mentioned that I had, I always mention them because I think we need to manage expectation. We need to tell people this may happen to you. Now, my wife and my son, they didn't get anything. They were just fine. So everybody doesn't get it, these reactogenicity effects. But if we don't manage that, we don't tell people about it, I think there is going to be a concern and people after the first dose may not come for the second dose. COVID death infections are being exaggerated. This is another one of those myths and untruths and conspiracy theory. This cannot be farthest from the truth. If anything, we believe that the deaths and infection of COVID-19 are probably being underreported, not overreported. So I think that's another myth. wearing a mask is not good for your health. Mask limits spread of infection. It is definitely good for your health. There's no negative effect on your health, to the best of my knowledge. No, in any disease you may have, underlying disease, asthma or anything, it does not cause it is any health effects. Now it may be uncomfortable, but it does not cause any bad effects on your health. So I think you make sure the infectious person does not spread to others. That is why everybody needs to wear a mask. The one who's infected and one who's not. It cannot work if only half the people wear the masks. COVID vaccine is similar to influenza. Again, this is also a myth, unfortunately, promoted by some politicians. COVID can kill up to, we know COVID can kill up to 10 times more people than influenza. COVID spread much faster than influenza. Infected person can be acutely infected for longer than with influenza. So that's another problem. And COVID also has long-term effects on heart and perhaps even other organ systems. We are hearing about this COVID fog affecting the CNS. So I think we have an effective oral, and we also have an effective oral ambulatory treatment for influenza, where none exists for COVID-19. There are some under trial with monoclonal antibodies, but for influenza, it's tablets, so it's much easier. So they are not similar by any stretch of imagination. Recently, a nurse died on camera after taking COVID vaccine. The nurse did faint and she did not die. I think it was a bad choice of a spokesperson. The nurse had a history of fainting spells. Those of us who use HPV vaccine for our patients, we know that the fainting spells have also been associated with HPV vaccine. So this is not new. This is not like a absolutely new side effect. With HPV vaccine, we also ask the recipient to stay in the office for about 15 to 30 minutes before they leave, because there were cases of fainting spells with HPV vaccine. So what vaccine does and does not do? One dose only protects until you get the second dose. There's some misinformation that the one dose is effective in protecting. It is not, because the way the studies were done, the first dose was given and the second dose. So we have no studies that will show that with one dose you will be protected. Now there is a vaccine which is hopefully going to be approved not too distant in the future. It's the Johnson or the Janssen or the J&J vaccine, which only has one dose. Vaccinated people may get infected and transmit infection. As I said, vaccines cannot cause infection. Standard coronavirus precautions may not apply after you get the vaccine. Again, we have to do facial covering, social distancing, and smart isolation even after we get the vaccine, because as I said, we may not get the disease, but we don't know if we can get the infections. For now, we have to continue doing all those things. Long-term protection is not confirmed. That is true, although we know now that the vaccine is efficacious for now it's 5 months, and we'll learn more about it. The participants in the studies are going to be followed for 2 years. But again, we know that the vaccine is efficacious, and we'll learn more about it. There are possible unknown risks. That's true for any medication. What we have to remember is that most adverse events after a vaccine occur within 6 to 8 weeks of getting the vaccine. So we did not see that in these trials. So I think the chances of serious adverse events later on is much less. And then there will be local systemic inflammatory responses or reactogenicity once you get the vaccine. I experienced that, and many others have. The other myth is those who have had the infection may not be able to get the vaccine. Yes, they can get the vaccine. They may defer it for 90 days because we know the risk of reinfection is very little in 90 days. They don't have to, but they may. You should definitely not get the infection during acute infection. You get the vaccine during acute infection. We do not give a vaccine, pertussis vaccine, to anybody who has pertussis, or influenza vaccine, somebody who has acute influenza. So that's not something new. We don't do it for other infections which have vaccines against them also. I'm going to skip the next slide. There are no data about interchangeability, which means that if you get the Moderna vaccine, there are no data to say you can get the BioNTech vaccine after that, or vice versa. However, the CDC has said that if you inadvertently get first dose with one vaccine and the second dose with the other vaccine, you do not have to repeat a dose. You do not. So even though there are no data, it seems like that you could. This may work. There's also no data of co-administration with other vaccines. That is why they recommend that you wait 14 days between vaccines. That goes back to, well, first of all, the studies where the studies were done, there was no co-administration of vaccine, so they had to wait 14 days if they got a vaccine. And the reason for that is there have been studies with other vaccines where they've shown that when you co-administer vaccine, there could be blunting of the immune response, either with the study vaccine or the other routine vaccine. So that's the reason it is recommended not to do co-administration. There are going to be studies for interchangeability and co-administration down the road, and we learn more about it. And of course, there's a question about immunization after use of monoclonal antibodies. And some people are recommending that you can wait 90 days. Others would say just go get the vaccine. This is not a live attenuated or a inactivated vaccine. Like the measles vaccine, we defer that after somebody gets immune globulins or monoclonal antibodies. So I think this is an area of much research and interest. Personally, I think if you can defer the vaccine for a little bit, that would not be harmful. That is my last slide. I will stop there and open it up for any questions people may have. Thank you very much for your attention.
Thank you, Dr. Rator, very much for that. Nazia Bhabhi, would you like me to start asking a few questions that have come through the chat?
You please.
Okay. So what I like to do is I like to open the floor up to Mr. Iqbal. Sir, it looks like you asked 2 questions. So if you'd like to unmute and ask those questions, that'd be great.
That's okay. I can see his question. Let me answer his question.
Okay. All right, sir.
His first question is, should we wait for the Johnson & Johnson vaccine? Is it worthwhile? My answer is no. We don't know when the Johnson & Johnson vaccine is going to be approved. It has not even been submitted for to the FDA. So I would say that we don't wait for that. We get the vaccine which is available and get it right away. No need to wait. It said, I'd like to get my parents in early, parents who are in early 70s to get vaccinated. Any reliable source you recommend near Lahore area? Unfortunately, the vaccine is not available in Pakistan. There are research trials going on. I'm not sure there's a research trial going on in Lahore, but I know Shifa is doing a research trial, Shifa International, and Ijaz, Dr. Ijaz Ahmed, who's one of our former trainees, is actually heading that trial. So you can check with them and see if they will, of course, when they enroll in the study, it's a placebo-controlled study, so that we don't know if they'll get the placebo or the vaccine. Sabah Mahmood has a question. Will the current vaccine be effective as new UK variant? The data so far, there are no data to suggest it will not be effective. We don't know that. The things with these, first of all, we don't have that much UK variant right now in the United States. We probably will have more of it, and then we will learn more about it. So I think at this time, I cannot say that it is effective or not. What I will say is I would get the vaccine. There are good chances that there are good biological plausibility that it's going to be effective because the variant also has the spike protein. Dr. Etsam Haq has a question. I don't see he has put it on there. So if you want.
Hi, I'm here.
Yeah, go ahead.
Dr. Rator, first of all, thank you very much, and Alliance also for second presentation. My question may be a little difficult, but I will ask it anyway. So this vaccine, almost all of our Apna physician has got it, almost. Now this year, my understanding is our leadership is planning for meetings. Let's starting with the spring meeting, which is generally 100 to 200 people. Then we have 2 international trips, and then we have summer and fall meeting. Now my question to you is, when our Apna leadership is planning for these meetings, definitely they will ask our input also in next few days, what we should be doing and what we should not be doing. Starting from international trip, let's see, we have a spring trip in May and fall trip in September, October. Most of the times, the people who go on these trips are somewhere from 50 to 300. I don't expect 300 this time. So what are your recommendations to our Apna leadership and the people who go to these international trips and the meetings, which some spring meeting will be in Philadelphia, summer meeting is in Orlando, where we should be expecting 1,000 to 2,000 people. all of us are vaccinated, most like our spouses
I
will.
think I understand your question, Dr. Hassan. Let me try to answer that. I think it's not just UPNA, but many other organizations are planning for fall and summer meetings. Everybody's planning. And the reason for that is I'm actually involved in the American Academy of Pediatrics and Florida chapter in our own meetings. I'm involved in many of them and planning for them. The reason we have to plan now is because we don't know what's going to happen in May, June, July, August. And it's easy, you know, with all the APNA, with the pandemic, as we are negotiating with hotels, we have a clause in there that we can always cancel it without any penalty. So I think planning is not a bad idea. Now, what will happen in May or what will happen in August or September remains to be seen. I have my best guess is that by May we will not be there. My best guess is by August, September, if enough people have been immunized, we will be in a much better place. And so you may start seeing our professional societies holding either hybrid or in-person meetings. So I think my response to would be keep planning, keep an eye out for it, and if you have to cancel, you have to then cancel. And I think you let the members know that this may happen. International trips really is a very personal decision. I got my first dose. I was planning to go visit my father after I got my second dose. Unfortunately, he passed away. So I did go to Pakistan. I did fly to Pakistan and I came back 2 days ago. And so I think that's my plan was to go after my 3 weeks after my second dose. That's something is a very personal decision. People are traveling. So I think those issues have to be dealt with. There's not a black and white answer to this. And I don't expect that there will be a black and white answer to this. But we will be more knowledgeable about this. I'm not sure by May, but I think by August, September, we should be in a much better shape. Khayyam has a question. Let me answer that. Will the vaccine have any influence on long-term side effects of infection disease like taste and smell? The vaccine has not, remember, this is not an infection. So the natural infection a lot of people have loss of taste and smell, and sometimes it goes on for months. Some people have still not recovered. The vaccine has not been shown to do that, but we'll have to keep an eye on that to make sure that is true. Nadeem Haq has a question. Is there any guidance on use of COVID-19 vaccine with MS or any other autoimmune conditions? In the study, they only included participants who were healthy. Later on in the study, they did include participants who were HIV infected, but controlled and stable. So there are no data on these autoimmune disease or other things. And the reason right now the CDC says that you should consult with your provider is because the risk of natural infection with somebody who has MS and autoimmune disease can be much worse than what you get from the vaccine. So I think many people have little concern that vaccine will in any way worsen that. Now, MS may be a little different because, other vaccines may have some issues with MS also. So I think that's why they said consult with your healthcare provider. I know for MS patients, many of them have said, don't get it. Autoimmune diseases, the people I know, the providers have all said, go get the vaccine. All right, let me keep going down this on the questions. Let's see, what percentage of population needs to get vaccinated to have herd immunity? My thing from the very beginning is 90 to 95%. I know early on, some people said 70%. I think 90 to 95% immunity would be necessary for herd immunity because that's what other vaccines, other diseases the same way, measles and others do very similar. Okay, then do vaccines cause infertility or miscarriage? Well, I laugh because they said the same thing about the polio vaccine, and I don't see population of Pakistan decreasing at all. So it does not cause infertility and it does not cause miscarriages. There's also, somebody may ask that question, can pregnant women and lactating mothers get the vaccine? The CDC say the studies did not have The studies excluded anybody who was pregnant, but they did have 23 women who got pregnant while they were on the study in the BioNTech Pfizer trial, and 8 women in the Moderna trial who got pregnant while getting the vaccine, and their outcomes are so far fine and they are being followed. So there are no studies, but both the ACOG and the International Maternal Fetal Society both recommend that the vaccine should be given to pregnant women, in large part because pregnant women have a high risk of morbidity and mortality for themselves and the unborn child. And so I think it is recommended to get that. I think the CDC says consult with healthcare provider, with your healthcare provider, but with the ACOG and Maternal Fetal Society recommendations, most of the OBGYNs are recommending that. What are your thoughts related to COVID-19 asymptomatic patients testing? I guess that's not vaccine related. I think getting tested is okay. It's just that your likelihood of being positive is less, but I'm not opposed to it. I think at least then you know, you need to, just don't forget that you need to get the right test. Don't get the antigen test or the antibodies. You need to get the PCR test. Will the vaccine be available to children ages 16 and under eventually by summer? So it's not 16 and under, it's under 16. 16 and older they can get the Pfizer BioNTech vaccine. And the studies for children are now starting. Right now, we have a lot of people who need to be immunized. So frankly, nobody's worried too much about 16 and younger. So I think if we immunize everybody, it is just as by my personal opinion. If we immunize everybody and we have tons of vaccine lying around, I bet you the Academy and the CDC would say, okay, start giving it to 12 to 16-year-olds, because there's no reason to believe that this vaccine would be any worse in terms of side effects or any less in terms of immunogenicity. But we don't have those studies. We don't have those data, but those studies are starting in earnest right now. I remember seeing a question on COVID vaccine from asking if vaccine recipients were pregnant. Okay, I think I answered that. People are coming to get rapid testing with the clinical benefit. I didn't see that, but I addressed that. Antigen test is basically useless if it's negative, but if it's positive, it is helpful. But as you know, most of the tests are negative, so you have to confirm a negative antigen test with PCR. Antibodies have really no role in clinical practice. They have a good, strong role in epidemiologic studies. Mortality rate in Pakistan is very...
Excuse me, Dr. Rathore, I want to interrupt you here. I'm doing, this is Dr. Maqsood Ahmed. I have clinical patient coming to the offices demanding rapid testing done. And it's very difficult to explain the patients that there's no much useful benefit of this, but they insist. So there's a lot of people, physician offices using antigen antibody testing, and I believe they're not informing the patient properly. So there's a lot of demand on these testing. So I wanted you to just make, as you said, I've been seeing these patients for the last 6 months, and there's not much significant of this doing it, but it is going on all over the country.
Yeah, I mean, there's lots of other things going on that are not right. I mean, all I can do is tell you what the data are, what the professional societies are recommending. We do rapid PCR tests in our office. We have a rapid PCR machine. So that's all I can tell you. I know it's challenging, it's difficult. I know there are some groups that advertise. I know in Jacksonville, there's a group that advertises antibodies and antigen tests. We don't accept that. We don't accept a negative test. And so I think that's something, I can't tell you any more than that. That's something people will have to deal with. Just because people are doing it, I don't think makes it right. The mortality rate in Pakistan is very low level, less than 2%. So it's not really life-threatening if you are healthy. Therefore, do you recommend vaccination if someone is healthy and is not immune suppressed? Well, we are not in Pakistan. The mortality rate in the United States is high. I just came from Pakistan. And but before I left, I was very skeptical that truly the rate is not high. Uh, and I think it is probably higher than what is being reported because, like I'll give you an example. My father passed away. In the US, we would have tested him for COVID-19, right? In Pakistan, we did not. So it's probably more than 2%, but clearly it is less than what we are seeing here. So there's some difference. It may have to do with the fact that the population is much younger. And I was there, and people are not really, a lot of people are not following any of the preventive recommendations. Um, in fact, what you're saying is that maybe the healthy people should not get it. Those are exactly the people who should get it, because healthy people can get COVID vaccine and can die of it. Two of my classmates from K 1983 class passed away from this disease. They were not young, but they were healthy. One in UK, he was an oncologist there, Tariq Shafi, and one in Pakistan, Dr. Ziaullah, who was a very well-known internist there. And they got this infection and they died from it. They were healthy people. So I would submit that I would not use that logic. Anybody who is at risk and is eligible should get the vaccine. How is it possible to get herd immunity in the near future if so many of the population is declining inoculation? Very good question. That's why all of us have to, that's why we are doing this session. That's why all of us have to go talk to people. That's why I encourage people. I posted my vaccine things on Facebook, not because I like to, but because I want to make sure that my friends and colleagues think that, I've taken it, I feel it's safe. And I cannot give anybody a recommendation stronger than I got it. Nobody's more, dear to me than myself. So I think that's the reason we do this. Let's see. Do you still need to wear a mask and avoid close contact? Yes. The reason for that is, as I mentioned in the talk, that we do not have data that suggests that you can prevent infection. We have data that you can prevent disease. That's how the study was designed. That only people who excuse me, the participants who got the got the vaccine, only if they got symptomatic, they were tested for COVID-19. So if we're asymptomatic, you were not. So we don't know that, but there are some data that will be coming soon. I expect there is going to be some protection against infection also.
Mubin bhai,
Yeah.
going back to my question about the herd immunity, what happens to those people who are refusing to take the vaccine? Are they being tracked to see if they are refusing and they're getting it? And then what is happening to that vaccine that's available for them? Can other people then get it?
Yeah, if you're not getting the vaccine, you're not being tracked. If you're getting the vaccine, you're not being tracked. You just put in the registry. You may choose to be on VSafe or you may not. But I think the people who are not getting this, no. So I think what it is right now, a couple of things. The vaccine is not approved. I think people need to understand it is emergency use authorization.
Right.
It is not full approval. What that means is you can't make it mandatory right now. The second part, I think, is also very important. There are more people that need the vaccine than the vaccine available. Now, what we have done, and many places have done that, what we did, once we were able to get all our frontline healthcare providers, then we were able to get all our rest of the healthcare providers in our system and our primary care physicians, all of them. Then we opened it up to the families of the healthcare providers. Then we opened up to medical students. Medical students actually got it earlier. Then we opened it up to if you had elderly, your parents. So when I went, my second dose yesterday, there were a lot of people who came just to get because they're older. We are giving the vaccine. So I think each state is doing it slightly different, but I don't think anybody is trying to hoard the vaccine. We just want to get the vaccine out to as many people who can get it. And so I think they said, there are a lot more vaccines still out there than has been given. So you'll see more and more opening up of the vaccine for other people. If they ask my opinion, and they have not, I would say just open it up to whoever wants it. I mean, at this point in time, you don't want to be sitting on vaccine.
There's one more question. I had somebody yesterday telling me that unless my whole family is inoculated, I am not going to be socializing with anyone. Now, is that?
I think that's fine. I mean, I got I got both my vaccines. My family is going to get their second dose first week of February. We are not socializing. I mean, we're not traveling. We're not doing any. We're only doing things that are absolutely necessary. I
No,
mean,
I meant, sorry, the people who have, like, if I'm vaccinated, you're vaccinated, so can we meet each other without fear?
well, you can meet each other, but you still have to wear a mask. You still have to do social distancing. You still have to do a smile because, as I said, infection is not. It will not prevent infection. Will prevent disease. What we mean is that if both of us have the vaccine and we meet and we get the infection, we may not get as sick.
Oh, okay.
So I think that's the idea.
Okay.
Have you studied the Chinese vaccine? Any concerns on their testing and efficacy, as those are the ones most likely to be used in Pakistan? I have not studied them. They are not available in the United States for studies. They are, unfortunately, the data are not available in the for any peer review. Some of the studies are still happening. I know there was a study from Brazil that was reported to have 78% efficacy, but it was reported by the scientists, researchers. Nothing was available for a peer review. So it may just be fine. The vaccine may just be fine. We just don't have any information on that. The vaccine, yes, you're right. The Sinopharm vaccine is probably going to be the most used vaccine in the world. It's available in the Middle East, in some South Africa, other parts of the world. And so I'm not saying that the vaccine is not safe or efficacious. All I'm saying is I don't know. Unless the data are made available and is transparent, we don't know. There's another question. Let's see. Khayyam says, with so many people resistant to following COVID contact precautions, have you found any phrases that convinces skeptical people to participate? I think there are categories of skeptical people. Those who have made up their mind. And nothing you tell them will convince them. But what you can convince are the people who are on the fence. And that's who should be worked with. Now, the other part is that anybody asks your opinion, you can give that. I have found that people who have already made up their mind, and it's very hard to, and there's no point in sort of getting in their face. What are your thoughts to immunize super spreaders who may, for example, go to, well, we don't know who the super spreaders are. We only find out about the super spreaders after they spread. So we need to immunize everybody. If we start looking for super spreaders, we never close that because control the pandemic, because super spreaders you only find out after they spread, not before. What are your thoughts to immunize? Okay.
Sir, you missed one question from Salman Tariq, Mr.
Okay, sorry.
1247.
Oh, I answered that, I think.
Oh, did you? Okay.
Yeah,
Sorry.
this is about the Chinese vaccine.
Okay, got it. Sorry.
Yeah, thank you. That was answered. Thank you.
Okay.
Any other questions?
Those are the only questions that I'm seeing.
Yeah, I think the most important thing that all of us can do is to make sure that we encourage everybody, we be very positive and enthusiastic about the vaccine, because that's all we can do. You're not going to convince people who are not going to be convinced. I have talked to some people and were able to convince them. Some got convinced when they saw me get the vaccine. I think there are also people who have seen, like we had a situation, one of our team members got COVID and got very ill. That convinced a few people to get the vaccine. So I think all of that is happening, but that's all we can do. We just need to be sure that we continue to. Let's see, I see there's one new message. Let's see, when will it be approved? Surya, what do you mean by when will it be approved? I don't understand.
The vaccine.
The vaccine was not approved, so therefore you cannot make it mandatory. So
Oh yeah, because see, even if the vaccine is approved, you still cannot often make it mandatory. It took us decades to get influenza vaccine mandatory. So I think, right now there's just not enough vaccine. We have 300 million people in the United States. There's just not enough vaccine already. So I think we need to focus on people who want the vaccine and just get the vaccine out. I should mention about the question from Pakistan. Just before I came back, there was a news by Faisal Sultan had made a statement that DARP, which is sort of the Pakistan's FDA, had approved the AstraZeneca vaccine for Pakistan. That means if somebody wants to import it, they can import it. And I think the vaccine, if I remember, was being sold by AstraZeneca. Don't quote me on this, like for $6. Now, $6 in Pakistani money is 1,000 rupees, and a lot of people can afford that. My concern is that when it comes, some private party will buy it and probably sell it at an exorbitant amount, and there'll be a lot of disparity because the people who can afford it will be able to get it. Others can. My suspicion is that the vaccine that will be used most in Pakistan would be the Chinese Sinopharm vaccine. Nazia, anything else I can do?
I just have one question. Somebody just texted me. Um, which lasts longer, immunity after getting COVID-19 or protection from COVID-19 vaccines?
Yeah, that's a very good question. The answer is nobody knows either, because you're asked, we don't even know how long the immunity lasts after COVID infection. Now, we do believe that in the first 90 days after the infection, so reinfection so far from COVID-19 is rare. It is even less common out in the first 90 days. So we know that. There are some data now that it is also very uncommon, rare in the first 6 months. So that's all we know. The vaccines are only being used for now, or for being the 2 approved vaccines. That cohort is being followed up for 5-6 months. So we don't know. So we're not going to know these questions until years later. If you recall the hepatitis B vaccine, we don't get a booster for that. And the reason for that is a cohort of people who got the hepatitis B vaccine have been followed now for 25 years. And every 5 years, the CDC follows them, see, what's going on. And so that's how the booster recommendation has not come out. So we learn as we go on how long the national infection protection after national infection lasts and how much after the vaccine lasts. Now, in some infections like pertussis, even if you get the infection, we still recommend to get the pertussis vaccine. So we learn about it. Somebody asked how much is the cost of the vaccine. I think for the United States, it's free. But the cost, I have it somewhere written down. They are, I think, for the Moderna and AstraZeneca, I seem to think they're anywhere like $20 to $25, and the AstraZeneca is like $5 to $7. They're basically selling it at cost right now.
Dr. Mubin, I got one more text.
Mhm.
And is this going to be an annual vaccine like the flu or one time only?
Again, that's a very good question. We don't know the answer to that either. The participants are going to be followed for 2 years. And then all of us who will sign up for the VSafe, we'll have some information. So we learn about it. The reason the flu vaccine is every year is because viruses mutate all the time. That's not big news. It's how much they mutate. It's a flu vaccine. Every year there's what we call a drift. That's a small change. And so you have to change that vaccine every year, make a guess. Every 10 to 40 years, there's a shift, which is a major mutation in the virus. And that's why every 10 to 40 years, there's a pandemic, a huge epidemic of influenza. So again, we forget that this virus is only a year old, 13 months old, and we're still learning a lot about it. There's a question here: to your knowledge, under what circumstances did the CDC recommend funeral services workers to get vaccine before clinical health workers? And can people who have passed away with COVID transmit the virus post-mortem? So we know that the virus can survive on inanimate objects for 3 days. So once you die, you're basically inanimate. So we think it will last for 3 days. That's why, at least in the state of Florida, if somebody dies of COVID, they are kept in the morgue for 3 days before they are released for burial. I think I'm trying to see if I understand the question. Under what circumstances does CDC recommend funeral service workers to get the vaccine before clinical health workers? I don't know. I don't believe CDC has recommended that. Health workers are Group 1A. They are way ahead of the funeral parlor workers. Another question: can a patient with a history of allergic reaction receive the vaccine? So that's a very good question. If you have had the general answer is yes. If you have severe allergies, you should certainly contact your allergist, now, especially if you keep an EpiPen. But you can still get the vaccine. That's why you have to wait there. You must have your EpiPen ready to be able to use it. So that's something, with most other infections, vaccine, we say the similar thing. Now, if you have an anaphylactic reaction or allergies to any of the components of the vaccine, then you should again consult with your healthcare provider. I think most people, if they just have an allergic reaction, they are getting the vaccine. Those with EpiPen, unless they have had an anaphylactic reaction, are also getting it. If you have an anaphylactic reaction, you may need a more controlled history of anaphylactic reaction. You may need a more controlled environment. Okay, I already answered that. What do you want to say to people who are nervous about it, looking to get the vaccine? All I can say is I've taken the vaccine myself. I've given it to my family has gotten it, and nobody is more dear to me than myself and my family. So if that is not strong enough endorsement of the vaccine, I'm not sure I'm going to convince them at all. Should acetaminophen or NSAIDs be taken prior to vaccination? Okay, so that's a very important question. I knew I got a first time reaction. I knew I'm going to get the reaction second time. I did not take that either. I was willing to go through that because there are some data that suggests taking NSAIDs can blunt the antibody response. However, there's no reason one to be so uncomfortable. So if you feel that you need an NSAID or Tylenol, you should do that. It's not contraindicated. I just made a personal decision, a personal choice that I did not take, even though I didn't feel very good.
I think that's no
questions.
The second dose be given later than 21, 20, or 28 days and still be effective. So I think as one of my slides said, we know what the minimum time is. We don't know what the maximum time is. The minimum time is 21 days or 28 days. The CDC has it because that's how the studies were done. And that's what the FDA approved. The CDC said you can give it plus minus 4 days of those two vaccines. Just on the 21st, CDC said you can give the second dose as late as 6 weeks. I got my second dose 8 days later than I was supposed to get it. So I think that's fine. But obviously, if you get into months, that's going to be a problem, I think. But, so if it's a little bit later, I think you should still get the vaccine.
I think those are all the questions as of right now.
Very good.
Thank you, sir.
Thank you very much, Dr. Rathore. On behalf of my executive committee, I would like to thank you for your time, effort, and the wealth of information you shared with all of us. I'm sure our members and friends and family will benefit immensely and from this vital information. Thank you very much.
My pleasure. Thank you. Everybody have a good day.
Thank you.
Thank you very much.
Okay, end of meeting.